Low libido in men over 60 is almost always a hormonal or neurochemical condition, not aging, not psychology, not relationship issues. It has identifiable biological causes, and in most cases, it is treatable. Today I am explaining the #1 clinical action that changes everything. I am Dr. James Whitaker, board-certified urologist, and today I want to address low sexual drive, low libido, in men over 60 with the level of clinical detail and honesty that this topic deserves and rarely receives. Low libido in senior men is dismissed by too many people, including sometimes by physicians, as an inevitable and untreatable consequence of aging. It is not. In my clinical experience, low libido in men over 60 almost always has identifiable, addressable causes. And when those causes are identified and addressed, the restoration of libido and sexual interest that men experience frequently transforms not just their sexual health, but their overall vitality, their relationship quality, and their sense of engagement with life. Today I am giving you the #1 trick, or more accurately, the most important single clinical insight that changes the trajectory for the majority of men with low libido who come to my clinic. That insight is this. Low libido in men over 60 is almost always a hormonal and neurochemical condition, not a psychological one, not a relationship one, not simply aging, and it will not significantly improve through willpower, relationship work, or simply trying harder. It requires identification and treatment of its biological cause. Let me walk you through the most important biological causes of low libido in senior men, because knowing the mechanism of your specific situation is what determines which approach will work for you. The most common and most important cause is testosterone deficiency, hypogonadism. Testosterone is the primary driver of libido in men through its actions on androgen receptors in the brain, specifically in the limbic system, the neurological circuit that mediates desire, motivation, and reward. Without adequate testosterone, the neurochemical environment that produces the experience of sexual desire is impaired at its most fundamental level. Men with testosterone deficiency describe their libido not as reduced, but as absent, not as reduced desire, but as complete indifference to sexual activity that they previously valued and enjoyed. This is qualitatively different from normal age-related moderation of sexual interest, and should be recognized as a clinical symptom. The diagnosis requires a morning blood test measuring total testosterone and free testosterone. Normal testosterone levels at peak morning measurement in adult men are typically accepted as being above 300 nanograms per deciliter for total testosterone, but this threshold does not uniformly apply to all men. Some men have significant symptoms at levels considered technically normal, particularly when free testosterone is low due to elevated SHBG. The complete hormonal assessment should include total testosterone, free testosterone, SHBG, LH, and FSH to determine whether hypogonadism is primary or secondary. Prolactin. Elevated prolactin from any cause dramatically suppresses libido through dopaminergic pathway impairment. And estradiol, since elevated estradiol, often caused by aromatization of testosterone in excess visceral fat, can suppress libido independently of testosterone level. The second most important cause of low libido in senior men is sleep disorder, specifically obstructive sleep apnea. Sleep apnea and the associated chronic sleep deprivation suppress testosterone, since most daily testosterone is produced during sleep, suppress dopamine pathway function, the neurochemical system responsible for motivation and desire, and produce a global reduction in vitality and engagement with life that manifests as libido loss among multiple other symptoms. Men with undiagnosed sleep apnea frequently present with low libido combined with fatigue, mood changes, and cognitive slowing, a constellation that perfectly mimics testosterone deficiency. Treating the sleep apnea with CPAP often produces significant libido improvement within weeks of effective treatment. Please subscribe to this channel right now. I am Dr. James Whitaker, board-certified urologist, and the information I am sharing today is relevant to a very large proportion of senior men who have been told their low libido is simply aging. Hit subscribe, hit like, and comment below right now. How long have you been dealing with low libido, and have you had your testosterone tested? Tell me. I read every comment and I want to know where men are starting from. The third cause is medication side effects. Multiple classes of commonly prescribed medications produce low libido as a direct pharmacological side effect. The most important in the senior male population are selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, which suppress sexual desire through their effects on serotonin pathways. Serotonin and dopamine are in a reciprocal inhibitory relationship for sexual motivation. Increasing serotonergic tone, as SSRIs and SNRIs do, reciprocally reduces dopaminergic tone and consequently suppresses libido. Beta-blocker medications, atenolol, metoprolol, propranolol, which reduce libido through their effects on central adrenergic pathways and through their moderate testosterone-suppressing effects. Opioid pain medications, which suppress the hypothalamic pituitary gonadal axis directly, reducing LH and consequently testosterone. Certain antihypertensive medications, and some urological medications including finasteride and dutasteride used for BPH, which reduce dihydrotestosterone, a potent androgen, and in some men produce persistent libido reduction and other sexual side effects. If you are experiencing low libido and are taking any medication in these classes, this is a clinically important connection worth discussing with your prescribing physician. In many cases, a medication switch within the same therapeutic class, or at a different dose, produces meaningful libido improvement without compromising the underlying condition being treated. The fourth cause is depression, and this requires nuanced discussion because depression and low libido create a self-reinforcing cycle. Depression, through its effects on dopaminergic and serotonergic neurotransmitter systems, directly impairs libido. Low libido, particularly in men who associate sexual vitality with their sense of masculine identity, produces depression. The cycle can begin from either direction, and treating only one pole while ignoring the other produces incomplete results. Men with low libido accompanied by persistent low mood, loss of interest in previously enjoyable activities, disturbed sleep, and reduced motivation should discuss both testosterone assessment and depression screening with their physician, since both conditions may be contributing simultaneously. The number one trick I am referring to in the title of this video, the single most important clinical action that I recommend to senior men with low libido, is this. Get a complete hormonal blood panel, done in the morning, before accepting low libido as simply aging. Total testosterone, free testosterone, SHBG, LH, FSH, Prolactin, Estradiol, TSH for thyroid function, complete blood count, and a comprehensive metabolic panel. This single morning blood draw, costing modest amounts with most insurance coverage, has the potential to identify a treatable condition that is causing your low libido and that will not improve without treatment regardless of how many lifestyle changes you make. Men who have been managing low libido through relationship counseling, changing diets, trying different supplements, or simply accepting reduced quality of intimate life, when the underlying cause is testosterone deficiency or sleep apnea or medication side effects, are treating the wrong problem. The symptoms will not meaningfully improve until the biological cause is identified and addressed. After the blood test, the treatment approach is determined by the findings. Testosterone deficiency is addressed with the combination of lifestyle optimization, sleep, exercise, body composition, alcohol reduction, and, if appropriate and desired, physician-supervised testosterone replacement therapy. Sleep apnea is addressed with CPAP, positional therapy, or surgical intervention. Medication-induced libido suppression is addressed through discussion with the prescribing physician about alternatives. Depression is addressed with appropriate pharmacological and psychological treatment, chosen with attention to the sexual side effect profiles of antidepressants. I am Dr. James Whitaker. Low libido is not your destiny. Get tested, get an answer, take action. Subscribe for weekly medical content. I will see you in the next video.